Good morning. Thank you very much for the invitation to talk to you this morning about clinical utilisation review. I'm Nigel Kee, the Chief Operating Officer for Basildon and Thurrock University Hospitals FT. We're in Essex, part of the Midlands and East region, and I've also got...
Good morning everyone, my name's Kelly French. I'm the Head of Operations at Basildon, standing with my boss this morning, which is always good.
We did wonder about whether we should spend opposite ends of the stage given our height differential.
I did ask for a step or something, but clearly that was missed. Yeah.
Okay, so just a little bit of context. I particularly like this quote from Sir Cyril, who said that medicine used to be simple, ineffective and relatively safe, but now it's complex, effective and potentially dangerous. And I think it's a really good reminder of the sort of world in which we work in. A few headlines, which Harry's going to make a few comments on that I'm sure some of these you'll be very familiar with.
Okay, so I mean these are some of the headlines that all probably haunted us and kept us awake over the last particularly 12, 18 months ago. I think there wasn't a day that went past where we wasn't collectively as an NHS on the news in some way or another. Not very positive. It was all about delays, poor performance, blockages, and these were the things that no doubt many of us kept us awake at night. We clearly weren't serving our patients as well as none of us wanted to, and something had to be done, and I think that's probably what we all needed, really, that little kick to ensure that we weren't being complacent, to ensure that we were being challenged and we were providing the best service. And none of us want to go back to that, and I think part of what CUR or CUR can give us is helping us unblock some of this, ensuring that our performance is where we want it to be. We're not delaying patients, etc., and all those horrible headlines that we see before us. This is a source of great amusement around our trust. If you don't recognise me, perhaps if I do that. It's a source of enormous ridicule, and thanks again to Nigel for ensuring that once again it's received by a nice wide captive audience. This was us at BTUH after our application to become an early implementer site for CUR. Many of us in the photo, I have to say at this stage, didn't know really much about it, what it was, but clearly we were all very happy none the same. Okay. So this next slide, we all know this. Emergency demand is growing. We recognise that completely. Go back to 2008, pushing 100,000. We've grown up to 25% in those few short years. Prior to that, I remember a young nurse in ED being ridiculed. It was me, basically. We used to have a bet on how many patients we'd receive a year. A couple of years before that, I got ridiculed for saying we'd go over 90. I was laughed out of majors, but I think I was actually right. But it's a bit of feeling a bit smug about that. But it was a point that curve has significant growth. And the next slide really just shows its statistic significance has been proven. But a 25% growth in attendances from 2011. That's for us at BTUH, but I'm sure we're no different from many other ED departments across the country. So I've alluded to it already. We did have a couple of very challenging winter periods. From the back of that, we were, as part of being the early implementer, we did have the reviews that looked at our bottlenecks, both at the back door and our processes at the front door, in order to see where are the wins, what could we do wrong, what could we do better, what could we improve. It was commissioner supported, of course, and as well as that, our commissioners supported a review of ambulance conveyances to our ED, and I think we found that 38% of conveyances to our ED could have been conveyed elsewhere. That's not a criticism of our partners from the ambulance service, it's just that there is that appetite for having that greater understanding of alternative pathways to EDs, and that's something that, along with our partners in our own SRG, we continue to work towards now. As I said earlier, we were successful in our application to be an early adopter of CUR. We're very much down that road now. I think Nigel's going to talk about a little bit more about what we found from our initial MedWorks audit.
Thanks, Ellie. So, as a Chief Operating Officer, of course, I was absolutely convinced that most of the delays I had were, of course, external, and that I had a pretty good internal, efficient organisation. Perhaps not. So we undertook an audit using the CUR tool. We actually audited just under 200 unplanned patient pathways. It was skewed towards medicine, perhaps for obvious reasons. And our audit showed that it was pretty consistent with what was being found nationally. That is to say that there was potentially a huge number of bed days that could be avoided if we had patients in the right place at the right time. So the reasons for the delays are typically categorised into three areas by either physician delays, hospital reasons, internal hospital reasons, and external reasons. So as you can see, I'm going to flick through these slides very quickly. Internal reasons counted for 72%, and external reasons for 27%. The positive in that is that it gave me a really good, sizable opportunity in terms of the improvement I knew that I could control and make sure that we could do within BTUH. It also discovered or highlighted for us that a lot of our patient flow processes were somewhat manual, they were subjective and in silos, and that we need a much better transparency around our whole system flow across the whole system. So this just graphically shows you where some of the delays were, but I just want to go into a little bit of detail around this. So again, it's roughly a third. A third of the delays were internal to the hospital, a third were physician related, and just under a third community related. So the top reason for the physician reasons were typically specialty to specialty referrals. So very typically I had patients waiting in an acute inpatient bed, waiting to be reviewed by another specialty. For us, there were 2 or 3 particular specialties that were quite problematic. Neurology was one of them, and that again highlighted some real good opportunity for us in terms of looking at how we could improve some of those delays. So again, just a little bit of detail around some of the hospital reasons for delays. There were delays in diagnostic imaging, either getting the patient scanned or, more importantly, the scans being reported. Delays in some of the interprofessional team advice and input, and delays with therapies. Now, my therapists got very agitated when they saw this. Therapies is not about therapists. It's about typically IV therapy, where we had patients who might have been on IV therapy, but they really did not need to be in an acute inpatient setting just to be receiving IV therapy. In terms of external, perhaps as you might expect, social care was the predominant reasons. But what was interesting is we looked at a postcode analysis of that, and you'll see a particular postcode, RM1, highlighted, and that was a postcode that was on the border between us and a neighbouring trust. So that was quite an interesting and quite a quick win for us in terms of really improving communication to those services. So just a couple of comments about how CUR can really help. It does make a lot of the data an awful lot more transparent. It's an extremely effective evidence-based tool. There is always clinical override, but interestingly, not once has that been exercised by any consultant in our trust. So that gives, again, a lot of confidence from clinicians that the actual tool itself is robust and actually is quite simple to use. Excuse me. It does give a better understanding of the pressure points across the whole health and social care system and some of the pressure points internally. It does provide a huge momentum in terms of altering the whole dialogue that we have. It's made capacity across the whole system a lot more visible to everyone, and it's made much better system thinking and working. And I think the other useful thing is that it has enabled us to really make sure that we're using the resources much more effectively across the whole system. So our community beds, for example, were typically had around a 72% occupancy rate. They're now in the 90s occupancy rate, and also much quicker, much faster throughput. And the CUR has been a useful tool to help drive some of that. And I think for me, one of the most important things that's completely altered the dialogue that we have with our clinicians. Nothing used to be more demoralising for our clinicians when I would badger them about how many discharges were they going to have today, or I need X number of empty beds to get the next lot of patients in. This has been a tool that's absolutely changed the fundamental conversation that we have with our clinicians. Our clinicians can see that it's a tool that can really help identify very easily, very quickly, those patients that don't need to be in an acute inpatient bed, and therefore we can get those patients moved on much quicker. It's a win-win for everyone. So a little bit about the so what, and a few comments around what some of the early results show. So what clearly it says that reducing the number of those patient stays where the criteria has not been met, that has certainly been a huge feature of the tool. There is a perception that the majority of the reasons for the inappropriate stays sit outside of the control of the trust, but CUR has been an extremely useful tool for challenging and changing that perception. It does absolutely highlight the fact that there's an awful lot of opportunity that sits within organisations and sits within local systems. The top internal-based reasons from the early implemented sites include awaiting therapy and other diagnostic tests or treatments, that whole MDT intervention, waiting a senior clinical decision to discharge, and medication-related, and the processing of a transfer or discharge from the trust. In terms of the economics, it's really partly on the back of CUR. We have just recently managed to close an inpatient ward, and that's at a time when our 4-hour performance has been improving. We're not quite at 95% yet, but we have got an improving trajectory, and yet we've still taken a ward out. So I think CUR has absolutely been extremely beneficial from that point of view. I have to say my finance director is breathing a huge sigh of relief. But it does give you an idea in terms of what some of the potential financial and economic benefits are as well. So graphically, it shows that if you combine the early implementer trusts, there has been quite a significant increase in terms of the number of patients that have been identified where the criteria is not met, up to 38%. That again features quite a big opportunity for any trust. And again, you'll get slides, copies of the slides, so you'll be able to look at this in a greater detail. But that's a breakdown of some of the main reasons why some of those patients are still there. So next steps, for us, it's about really making sure we continue to embed and systematise CUR throughout the organisation. It has absolutely been a contributor to changing our organisational culture and the way we do business and the way we manage our emergency care system. We've become quite interested in terms of how we might implement this across 3 acute trusts, which is part of our STP footprint, otherwise known as the Essex Success Regime. And then the other 2 steps Kelly's going to talk about in terms of the report and the new critical care module.
So, thanks, Nigel. So, I mean, absolutely right. I mean, with my sort of operational hat on, the reporting is really the crux of the matter. We've done the piloting, we've done the testing, we've done the hearts and minds and engagement, which was quite challenging with some of our clinicians, but eventually we've got them all on board. And now it's a case of, okay, so now what? We've done the really, really challenging bit, the embedding, the change of culture and all of that. Now we get to the reporting bit, and this is the exciting bit for me, because currently, I hope we're no different to many other DGHs, that we have our capacity meetings, and when things aren't looking good, we run around, we look at who's going home the next day, who could go, everyone becomes a site manager, if you like, involved in capacity, trying to forecast what we can do, what other areas we might need to open, how many predicted admissions and discharges we'd likely to have for the remainder of the day. But we're now at that point, instead of having to send people off to find this information, we're completely and utterly proactive in terms of it, because we are just going to have that report sent to us 15 minutes before our capacity meeting on a typical afternoon. So we'll know. We don't need to run around. We don't need to pull people off the wards. We can keep nurses on the wards, and all these advantages, because we know, because of the reporting, it's going to tell us what's happening, because it's been done every day, because it's been done with people who know the system, who are engaging with the clinicians to make sure that what they're saying is accurate and believable. We've got our partners from social care, etc., and our other neighbouring trusts that partner trusts in the community, etc., that we work alongside with. They're all engaged and they're all bought into it. So we know what we're reporting at that press of the button is going to be accurate. So we're not second guessing anymore. It's going to be a big step change for us. And we're all really looking forward to it. And it will, sorry to labour the point, but it will stop some of this kind of running around, not exactly like headless chickens. I wouldn't want to suggest we do that at all. But there's certainly that, that kind of anxiety about how we're going to bridge the gap. But now we know, which is really useful. For me as head of operations, but obviously importantly for Nigel as well as the coup. We're not quite at this point yet, but we've started the dialogue, our critical care module. This is also a huge opportunity. It's going to be really exciting for us. We do have difficulties getting patients out of our critical care because of the capacity constraints. We know it's the biggest priority. We know we must have patients. We must have critical care beds available for our sickest patients, and that's something we strive to do every day. But again, once we introduce the module, we will have complete and utter knowledge of who are the level 2s, who are the level 3s. Moreover, we'll have knowledge of which level 2 patients we've got outside of critical care. Are they deteriorating? Are they improving? So do they need access to, and we can start our planning earlier. We also have an outreach team who rely on referrals from colleagues on the wards. We won't need that anymore. It will be far more organised, because Kerr will tell us who's deteriorating, and they will get the report, and they will know the top 5 or 6 patients they need to go and see and beyond. So that's a really exciting opportunity. And my colleagues who work in critical care can't wait to get started on that. And that's, I think, one of the biggest things we're looking forward to in the next sort of quarter, I think.
So, in summary, just a couple of other points. CUR is a bit of a journey that we're really pleased that we're on. We know that we're not there yet, but we're already seeing some huge benefits in terms of being able to use CUR as the everyday part of our way in which we do things within BTUH. We're also looking at how we build it into our business continuity planning, and I was really struck by a regional hospital in Canada that had a major flood. And a typical tower block, their critical care unit was on the top of the tower block, and they had to evacuate urgently the entire hospital. And they used CUR to be able to tell them within 22 minutes every single patient and where they needed to be, whether they really did need to stay in hospital or whether they could go somewhere else. And so I think CUR has some added interesting features in terms of how we build that into our business continuity. But again, it's a tool that's completely changed the way in which we interact with our clinical colleagues, and it's a really simple tool to use. To assess every patient on a ward, it takes around 15 minutes once you become familiar with the tool. So it's not time-consuming at all, and yet the data that it's producing is changing the way in which we're doing business.